Topic of today's lecture is the vermiform appendix. By the end of the lecture, the final year MBBS students will be able to understand acute appendicitis, its symptoms, sign, presentation, and its treatment. Now, regarding the anatomy of appendix. Appendix arises from cecum. Basically, what happens is that three tinea converge downwards at the lower end of the cecum at the site of convergence of these tinea arises the base of the appendix, and it is present close to the ileocecal junction. Appendix is a blind outpouching of cecum which is composed of all four layers of small gut, that is mucosa, submucosa, muscularis, and serosa. Now, coming to the blood supply of appendix, appendix is supplied by a branch from ileocholic artery, which is known as appendicular artery. The appendicular artery runs in the mesentery of appendix, which is known as mesoappendix, and thus it supplies the appendix. Appendix is never constant in position, it has multiple positions. The commonest position of appendix is retrocecal or 11 o'clock position. In around 74% of the population, the position of appendix is retrocecal. The second commonest position of appendix is pelvic or 5 o'clock position. The rest positions which are not so common are the pre-ileal positions, post-ileal positions, and the subcecal positions. Rarely, another position which is again not very common is a paracecal position as well. But the most common position, as I've already told, is retrocecal position. And it is this position that makes it very difficult for an ultrasonologist to diagnose or examine appendix on an ultrasound examination, because due to cecum, the sonologist cannot see the appendix on the ultrasound. Now, what is acute appendicitis? Acute appendicitis is acute inflammation of appendix. It is rare in infants, and as well as it is also rare in old age. Its peak incidence is in teens and early 20s. Basically, etiology is not known, but the causative factors can be presence of a fecal length, presence of a tumor, or presence of parasitic infestation. Now, how does generally acute appendicitis present? A patient of acute appendicitis may present with vague abdominal pain symptoms. The pain may arise in periumbilical region or rarely in epigastric region. Initially, it can be very vague pain that later shifts to the right iliac fossa. Patient may also complain of associated nausea, vomiting, or anorexia as well. Patient may have low-grade fever as well. At times, few patients may also complain of constipation, especially if a patient has pelvic appendix. These patients may also complain of diarrhea, or at times patients may complain of abdominal bloating as well. When we examine these patients, generally they are tachycardic, they are febrile, and they point towards right iliac fossa. When they complain of pain, they point towards right iliac fossa. When we ask them to cough, they specifically point towards right iliac fossa, and they complain of pain in right iliac fossa. And if we palpate in right iliac fossa, uh, they do wincing and they experience pain. And if we lift hand while palpation, the pain is increased. This is known as rebound tenderness. If we palpate in the left iliac fossa and lift our hand gently, the patient experiences pain in the right iliac fossa. This is known as Rovsing's sign. And this Rovsing's sign is again suggestive of uh, acute appendicitis, and it occurs due to irritation of the peritoneum due to inflamed appendix. If the appendix is retrocecal in position, it can be confirmed by mildly hyperextending the hip joint. When the hip joint is hyperextended, the retrocecal appendix, which is lying on the psoas muscle, it irritates the psoas muscle and pain is increased. So, a psoas sign is said to be positive. Similarly, if the appendix is pelvic in position, it is lying over the obturator internus. If we flex the hip joint and internally rotate it, then the pain is increased. This is known as obturator sign. So these signs are used so as to uh, not only to diagnose clinically acute appendicitis plus to estimate the position of appendix as well. Now, while diagnosing acute appendicitis, we also have to rule out certain other common diagnoses. For example, in adults, especially in adult males, we have to rule out ureteric colic, testicular torsion, and in both males and females, we have to rule out perforated duodenal ulcer, terminal ileitis. Especially in adult females, we have to rule out pelvic inflammatory disease, Mittelschmerz, torsion or hemorrhage of ovarian cyst, and ruptured ectopic pregnancy, which is a very, very common differential diagnosis in these patients. Regarding investigations, we send for routine investigations, including a complete blood count, in which we go for neutrophil counts and urinalysis. We we want this to rule out urinary tract infections, and for selective investigations, we go for pregnancy tests, urea creatinine, electrolytes, ultrasound, especially in females with reproductive age, that is from 15 to 45 years of females, and CT scan abdomen, focus CTs for appendix, especially in doubtful cases. Basically, acute appendicitis is a clinical diagnosis. It's a history and examination based diagnosis. But in few cases, when there is a diagnostic difficulty, then CT scan may be required. When diagnosis is made, and after diagnosis has been made, then the definitive treatment of acute appendicitis is surgical, and that is achieved via appendectomy, which may be done via open approach or laparoscopic approach. And for open approach, different incisions are made according to the will of the surgeon. Many surgeons make a gridiron incision, and some, like me, like I prefer a skin crease veins incision. In older times, they used to go for a lower midline incision, which is obsolete now. The further recent advances are more surgeons are now um, preferring laparoscopic appendectomy, which is a further better approach for treating acute appendicitis. In safe hands, laparoscopic appendicectomy is a very safe procedure, and it leads to very early patient recovery and excellent prognosis, excellent patient mobility, excellent recovery, and patient is sent back to home very early uh, after laparoscopic appendicectomy. And in this way, appendicitis is treated. Thank you. Thank you very much.